intra-abdominal complex hernia and avoiding TEP procedure, making the TEP a universal laparoscopic approach for inguinal hernia. There's no disclosure to say. When you find a so huge inguinal hernia which does not reduce after general anesthesia, and you perform the TEP exploration and you find a very large hernia which cannot be reduced, you have to avoid to create pneumoperitoneum, which will prevent from TEP procedure, and it will maybe deal with a large peritoneal tear, which may make TEP impossible. So, after making a conversion to laparoscopy through the paraumbilical access, which we use for TEP approach, we can see that the hernia does not reduce by pushing the hernia through the abdominal wall, and we use the same trocars which are placed in the peritoneal space to get access to the intraperitoneal view, so that we can get the instruments in and we can reduce what we could not reduce previously during the exploration. So we retrieve the small bowel and now the large bowel, and we can also clear all the attachments of the large bowel to the hernia sac, getting a complete reduction of the hernia contents. It has sound, the video. No, this is Eric Clapton going to the left. So we can retrieve all the large intestinal content, and we can now explore the hernia sac through the intra-abdominal laparoscopic view. That is the point that then we can turn down to TEP approach, which we have not changed anything, and now we can deal with the huge sac and to retrieve and reduce the large direct hernia. So, the question is that when you have this problem, you just have to turn your trocars to the intra-abdominal view, and now you can get access. You can reduce the large hernia through the TEP approach once again after you have changed from the intra-abdominal view, and you can perform your operative treatment of via transperitoneal. We have shown this procedure for 3 more examples. One is giant inguinal hernia with its on the right side. Can we have slide, please? Yeah. And now you'll see 3 cases. The first one is that is the term when you perform the TEP, you try to reduce the content of the huge hernia sac, which is an indirect and inguinal hernia, but you open usually the sac so it gets formal pneumoperitoneum. You turn into laparoscopic approach. You can reduce a small bowel, which was fully herniated in the indirect sac, and afterwards you come back to the peritoneal procedure. You reduce this huge sac, which is even difficult to deal with it in the TEP. You can see here very hard sac. This is the left side. You can also take this for the left side. Once you perform the TEP approach, you can see there's a huge hernia. You turn into intra-abdominal view. You can reduce now. You try to reduce it through the TEP approach, but you find you cannot perform the TEP approach, so you get once again through the intra-abdominal view, and once you get to the intra-abdominal view, which will take a few seconds, I think. Okay, now you're in the intra-abdominal view. You find the sigmoid column has herniated through an indirect sac, and it shows some signs of inflammation due to chronic incarceration. And then you come back to the top TEP approach. You dissect this huge sac, which is also difficult because large sacs do make some decrease of peritoneal space due to chronic adhesions and so on. This is the huge sac here. Sorry. You can see a very huge sac occupying all the myopectineal orifice. The vas deferens and the cord. This is the phase where we perform a pocket through the anterior aspect of the epigastric vessels to push them. And one application of this approach is that when you have a postoperative bleeding in TEP procedure with extensive intraperitoneal hemorrhage, you can also use this approach. You can deal with the huge preperitoneal hematoma. You can wash, drain it, localize the bleeding point, review how the mesh was, and it was displaced by the huge hemorrhage. And after you can see from the intraperitoneal view how the huge preperitoneal hematoma was displacing all the peritoneal cover, and also to retrieve all the blood in the subphrenic area. So it's one application from this approach. That is the TEP coming to laparoscopy, and after TEP. You can see here the little point bleeding, which is a corona mortis, as said, German here. And after complete hemostasis has reached it, you can go out. Now no bleeding at this point after extensive lavage. Review of the mesh. So this is the approach to huge and complex inguinal hernia. You don't need to tap, you don't need to convert to open surgery, you just have to come to a laparoscopic approach through the same process of the wound. So, thanks for your attention.
Thank you. When you turn to the TEP procedure, do you have to interrupt the peritoneum? So the pierce of the peritoneum does affect your vision when you go back to a TEP procedure?
No, because when you enter the peritoneal abdominal cavity, you perform the entrance to the peritoneum in a straightforward fashion. That is, when you enter the TEP approach, you enter in oblique fashion. So the peritoneum closes by itself and doesn't make any problem with.
There are some cases in which you cannot reduce easily the contact of the hernia because there are adhesions with the sac or the sliding hernias. So you are obliged to open a flap like in a TEP, TEP, and so complete your procedure with the TEP, TEP.
Yeah, that's right.
Why don't you go directly with the TEP? I say this because I have abandoned in 2000 the TEP after 500 cases of TEP. Now I perform only TEP for laparoscopic approach because I think that is very easy. Is a perfect operation, the TEP, but for a simple hernia, not for sliding hernias, scrotal hernias, and not when you have prosthetic material in the preperitoneal space. The TEP is impossible or is difficult.
Okay, we reserve the TEP just for re-hernia after a TEP procedure, and our philosophy is to perform, if possible, always TEP, and to avoid TEP, because we still think that although your closure of the peritoneum is almost perfect, it may develop some problems, adhesions, and so hernia and so on. So our philosophy is to keep the goal in TEP procedure, and if only there's the last chance to turn into TEP.
Are there any questions from the audience? No? Thank you. Next speaker, Dr. Planells.